Okay, so first of all, thank you for inviting me to give a talk on environmental medicine, specifically altitude medicine. So the reason I got asked is that I'm the faculty advisor for the Wilderness Medicine Student Interest Group at McGill. And Cassandra Poirier is the president of the group, and she had just recently given a very excellent presentation on extreme altitude medicine with a lot of personal experience. And I thought about asking her to borrow her talk, and I thought it'd be much better if she actually gave the talk with me. So we'll get ourselves introduced, but Cassandra will do most of it, and I'll do the pathophysiology part, so she can be more entertaining and I can be more boring. But of course, the pathophysiology makes you understand everything that we do about altitude medicine. So that's my preface. Sandra's controlling the slide, so Cassandra's gonna next slide. All right, so this is what we're going to talk about. A little bit of an introduction to us. Some physiological responses to acute hypoxia, and then we'll go over acute mountain sickness, high altitude pulmonary edema, high altitude cerebral edema, and how to prepare for a climb for those who are interested in how to pack for an expedition. All right, so this is me. So most of my adventures are at sea level and preferably on water. But I have been to altitude. So I did the Annapurna circuit in Nepal, and Torlung Pass is at 5416 meters, and that's the photo on the screen. I don't know how many of you had done the Inca Trail, but if you do the classic Inca Trail to Machu Picchu, the highest pass is at 4215 meters. And if you've skied in Colorado, Loveland Pass, which is on the Continental Divide, is at 3655 meters, and Arapahoe Basin, which is just beyond Loveland Pass, runs between 3200 meters at the base and 3900 meters at the peak that you can actually ski. So I have a little bit of experience at altitude. I'll let Cassandra introduce herself.
All right. Hi, everybody. Thank you for having me. Oh, can you hear me? Okay.
Oh, I have to, I'm unmuting myself.
Yeah, sorry about that. We're coordinating things. Thank you for having me. I'm really excited to be here. So I'm a fourth-year medical student at McGill. Before med school, I was actually working with Rob in the emergency room at the Children's for many years. And aside from that, it's been maybe about 10, 12 years that I've been into high altitude mountain climbing, extreme altitude mountain climbing. So I just put some of the summits I've done on the side over here. This is me over here. I'm not sure if you see my cursor, but this is on Aconcagua on maybe day 6 or 7. That's the highest summit I've done. It's about a little less than 7,000 meters, and it took about 3 weeks to climb. Aside from that, I used to live in India for about 6 months, and I did a bunch of mountain climbing in the north, a lot of stuff in Colorado and the Adirondacks, just local things that I can do in the weekends. So I'll stop it there, and I'll give the mic back to Rob.
Okay, so when we talk about high altitude, we have to decide what we're actually talking about. So, so 3 categories: so high altitude, very high altitude, and extreme high altitude. Just to put things in a context, so in terms of altitude illness, if you ascend abruptly to 2,500 meters or above, you actually may have symptoms of acute mountain sickness. And you probably will experience some shortness of breath on exercise, especially. So 2,500 meters is 8,000 feet, which is what commercial aircrafts are pressurized to give you a little bit of a context. Denver, Colorado, which is the Mile House City, sits at 1,600 meters, and Cusco, which is the entry towards the Sacred Valley and Machu Picchu, sits at 3,400 meters. So when you fly into Cusco, you certainly do have some symptoms when you arrive. The highest permanently inhabited human habitation is in Peru. It sits at 5,100 meters. which is very high altitude. And beyond that, extreme high altitude is above 5,500 meters to the peak of Everest. And this is really the domain of mountain climbers and mountaineers. And you cannot physiologically adapt and acclimatize to those levels. You can only stay there for a very short period of time. So for the most part, when we're talking about high altitude and high altitude illness, we're talking about ranging into the very high altitude area, so the 3,500 meters to the 5,500 meter range. So want to see where you have been as far as the audience. We have a little poll. Let's see if this will, hopefully this will work. All right, so how high have you gone? Have you been at extreme altitude, very high altitude, or have you pretty well stayed around sea level? You should be able to see this on your screens. So far nobody's voted. So can you see that?
Dr. Primavesi, I think we have to fill out all the questions and then we can press submit. So I don't know if you want us to fill out the.
Was that right?
I think so.
Ah, okay. We should have done one question at a time, but okay. So we can. All right. I don't know how to. You know what? Let's. You know what? We'll actually have you do this.
I'll edit the poll on Zoom. Hold on. You can end the poll and I'll try and edit it online.
Okay. Well, why don't we'll actually go to the next slide and we'll come back to the poll. Just having a bit of an idea of people's experience when it comes to altitudes. We'll take the next slide and we'll come back to the poll when it's ready. Okay, so of course the issue with altitude is primarily hypoxia, and we know that even though the percentage of oxygen in the air is the same at sea level and at the top of Mount Everest, the atmospheric pressure is less, and therefore the PO2 is less, and that compares the PO2 at sea level, the PO2 at Everest being 53 millimeters of mercury. And again, to put things into context, 2,500 meters on a commercial aircraft, everybody saturates at 93% because of the partial pressure of oxygen. And once you get to 3,000 meters, you're on the downslope of the oxygen desaturation curve, so that your O2 sat and your PO2 plummet precipitously as you go beyond 300 meters. So it requires an adaptation to be able to live at that at those levels. All right, so what happens physiologically to acute hypoxia? So a lot of stuff on the slide, but it's all very important in terms of understanding what happens and how we actually prevent and treat acute altitude illness. So because of hypoxia in the lungs, you get pulmonary vasoconstriction to try to compensate for the VQ mismatch, and that results in elevated pulmonary artery pressures. When you're hypoxic and short of breath, it's normal that you're sympathetically turned on. So your heart rate goes up, your blood pressure goes up, your cardiac output goes up, and your O2 delivery to your tissues goes up. And because you're hyperventilating, you actually develop an acute respiratory alkalosis. All right. In response to that, you actually have a diuresis, and you have increased erythropoietin production. This is more on a long-term adaptation, which increases your red blood cells and your O2 delivery to tissues, and so you actually have increase in your hemoglobin concentration. And you also get a increase in your vascular endothelial growth factor, which produces angiogenesis in areas where you don't have blood cells before. So again, increases blood supply to tissues, but it also increases vascular permeability. So the important thing about respiratory alkalosis is that eventually, if you're at altitude for a while, you will start getting a compensation. What happens is your kidneys waste bicarb, all right? And so you get a compensatory metabolic acidosis to balance out your persistent respiratory alkalosis, and that neutralizes your pH. So interesting fact is that many athletes will actually train at altitude because of the compensatory mechanisms, that it will naturally increase their erythropoietin production, increase their hemoglobin concentrations, and increase their O2 delivery to tissues. Athletes have also been known to dope with erythropoietin, but of course that is now detectable. So it actually is used. No, it's fine. All right, so with that in mind and understanding what sort of happens physiologically, we're going to meet Barbara, who's on a climb, and I'm going to hand things over to Cassandra.
Okay.
So Rob, actually, if you wanted your if you want to do your first question now, you can click the little arrow on top of the poll, and you'll see that there's poll 1, 2, and 3. If you go to poll 2, that's your first question, and I'm going to be fixing the other questions as we go.
Okay, hold on. So we're going to poll. So I still see the same first poll.
Oh, it's at the top.
Oh, at the top?
Yeah.
Little arrow?
Yeah, Cassandra's going to launch it. There we go.
Yeah, I think it's just still interesting to know where people have been, so we get an idea of what you've been exposed to. Okay, cool.
We'll try to let them see as many people, encourage as many people to vote as possible. There we go. I think people have to find the poll. So there's still 16 of you who are not sure where they've been. Yeah, that's fine.
Yeah. Share the result. Okay. So I'll just put this up right now. So I just find it interesting to see, like, where everyone else has been. A lot of people, most people have been at less than 1,500 meters at sea level mostly. One person has been at like extreme altitude, so very cool. So, again, share your insights with the group as we move on through the cases. So I created several cases just based on one, the literature, and two, personal experience. And we're going to be climbing Aconcagua today. So we're going to make our way up the mountain. I'll stop sharing these. Okay, good. So we're going to meet Barbara. Barbara, you're a team leader of a group of 8 climbers on day 2 of a 20-day climb up Mount Aconcagua, which is in Argentina. It's a little less than 7,000 meters high. You're trekking to Los Penitentes at 2,743 meters, and you're carrying about a 30 to 50 pound pack. That's typical when you're going up to base camp and you have your mules carrying the rest of your equipment. This is just your day gear, basically. So her chief complaint is that she's found clutching her head around the campfire at breakfast, and she's complaining that she feels hungover. You go see her and you see that she's been having a lot of headaches, intermittent lightheadedness, a racing heart. And of course, like everyone else in the group, she's been having a shortness of breath, slight shortness of breath while climbing yesterday. She's not been sleeping well, mostly because she's taking Diamox and she has to go urinate several times a night. Aside from that, you're very thorough. You do your whole review of systems. She has no nausea, vomiting, loss of appetite or fatigue or edema in her extremities. And she didn't drink alcohol since the start of the climb. So what are we thinking so far? I'm going to mute myself and I'm going to see if people want to unmute themselves or share in the chat what you might be thinking in terms of what you might have. 1 second. All right, so I'm not sure what's going on, but it's okay. So if no one's like, kind of stomped for what she might have, she has, we'll go
Sorry,
here. This is on your differential. So acute mountain sickness is definitely the highest one given the context, but it's also important to take into consideration everything else that she might have. Is she dehydrated? Has she been drinking enough? You're losing a lot, one from your breath and also from that natural diuresis that happens with increasing altitude, and two, helped with the diamox, which I'm going to go over the pathophys in just a bit. Oh, there's a chat. No one else can see the slides. Okay. Okay. Okay, great. So I just get like some typical vitals. She's a little tachycardic. Her rest rate is normal. She's satting at 90%. This is normal at this altitude. And let's say you're an ER resident. You brought your stethoscope, of course, on this expedition, and you listen to her lungs, and they're clear to auscultation. Normal neuroexam, including her mental status. And so it's just important to keep in mind, of course, anything else that might be causing these symptoms, not just AMS. Just some fun facts here. So people feel altitude, they adapt to altitude in physiologically the same way, but they may experience it in different ways. Some people may just feel their heart rates a little faster at rest or with any level of exertion. Some may have, be breathing a little bit faster, maybe peeing a little bit more, or have shortness of breath on exertion that resolves quickly when you're at rest, which is good. And of course, poor sleep with frequent arousals, insomnia, and vivid dreams, and increased incidence of central sleep apnea. So again, if you are someone who's known for sleep apnea, there's actually a really cool machine that you can bring on the mountain. It's about this size, and that basically replaces your CPAP on the mountain. And transient lightheadedness, especially if you're moving from a lying down or seated position to upright. Okay, so AMS, it's really, AMS and the high altitude cerebral edema represent a continuum of progressive neurodysfunction. So AMS being of course, the lower end of the spectrum. 22 to 77%, are on the big screen again. 22 to 77% of travelers between 1850 to about a little less than 6,000 meters may have AMS. And of course, the higher you go, the higher the likelihood of you getting AMS symptoms. So I'm going to show you the Lake Louise scoring system that's been used for it. On the mountain, you don't typically use it. You just do like a screen. Okay, are you having headaches, any nausea, vomiting, fatigue, lightheadedness, dizziness, or difficulty sleeping? And usually at this point, everything is normal, intact neurologically. So people can develop it 6 to 10 hours after ascending. And as Rob said before, you're starting already at quite an elevation. You're not starting at sea level, especially if, for Kilimanjaro, you're starting at, I think, about 2,900 meters, and then you're making your way up to 5,600 meters. And they can happen as early as an hour. So it's really variable from one person to the next. 1 second. There we go. So again, just speaking from personal experience, this is not really used on the mountain, but it's provided by the Wilderness Medical Society. It's the Lake Louise symptom score. So again, all the things that the symptoms I mentioned, so the headaches, the GI symptoms, fatigue, weakness, dizziness, lightheadedness, and difficulty sleeping, and you score them. All right. And I just wanted to include this because we typically think it's like, oh, you have to be in Nepal to have very extreme altitude, or along the range over here of the West Coast. But, again, you can have the Swiss Alps over here where people do have higher incidences of altitude sickness. Okay. And so some questions that people may have, okay, is altitude sickness more severe the higher you go? And this is what we're seeing over here on the left. And the faster you go, yes, this is correct as well. So we could see that on the right side of the graph. So, and the mild, moderate, and severe, that has to do with the severe in terms of your symptoms. Are they mild symptoms or are they more severe? So the higher you go, the greater the proportion of severe symptoms. And then also your faster rate of ascent, more AMS, and also higher severity. Oh. We have some technical issues in this room. I don't know. All right. Here we go. Okay, some factors that can affect high altitude illness is like you're going too fast and too soon. So on Kilimanjaro, they'll often say poli poli, take your time, give yourself time to acclimatize. And also think about your altitude goal, what you're starting at and what you're going to be increasing every day. Your previous history of AMS. So this is one factor. If you've had AMS on other mountains, there's a high likelihood that you're going to have it on your next climb as well. And just because you didn't have it on your other mountains doesn't mean that you're not going to have it on your next one. But there's a lot of inter-individual variability. I didn't include all of this, but there's some studies that have looked at the genetics underlying physiological adaptations to high altitude, and also the temperature drop, of course. So this is Diamox. This is what I was talking about before. Barbara's taking her Diamox. This is acetazolamide. It's used for the prevention of AMS. So you'll start the day before ascent and you'll continue for 2 days at the max altitude that you're at. How it works, and I put this on the side over here, is just to show you the hydration of carbon dioxide and then being transformed to carbonic acid right over here. And Diamox comes in by inhibiting carbonic anhydrase. What is this doing? So the primary problem in increasing altitude is respiratory alkalosis. And you have your kidneys that then kick in and start provide a little bit of metabolic acidosis. So acetazolamide comes in to help with this, push this as a metabolic acidosis a little further to counteract that respiratory alkalosis. It does so by preventing the hydration of the bicarb, of carbon dioxide, and basically leads to bicarb wasting. You prevent the resorption of bicarb at the proximal tubule. It doesn't just act at the kidneys, it acts also on the lungs, the heart, and even the brain. It can actually disinhibit the central chemoreceptors, stimulating ventilation, improving oxygenation, which is super important, especially at night when that respiratory drive to breathe is it's not conscious. So it helps with the acclimatization, but some things that can happen, and this has happened to me every single time, is like peripheral paresthesias, polyuria. You're going to be getting up a lot in the middle of the night to pee. And not that I've ever brought a carbonated beverage on the mountain, but apparently you can get flattened taste of this. Nausea, drowsiness are also things that can happen. Okay, good. So I'm going to mute myself and let Rob take over for this.
Okay, so when we talk about the progression of AMS to HAPE and to HACE, high altitude pulmonary edema and high altitude cerebral edema, so we're talking about the lungs and the brain. And the lungs we've actually talked about already, right? So you have hypoxia, you have vasoconstriction, you have elevated pulmonary artery pressures. You also have more leaky capillaries due to the vascular endothelial growth factor, and ultimately that results in high altitude pulmonary edema. In the brain, hypoxia has the opposite effect. It actually causes vasodilation. So you have increased cerebral blood flow. You eventually have loss of autoregulation. You have overperfusion of the brain, and you get vasogenic edema, which leads to high altitude cerebral edema.
So we're going back to Barbara now. So at this point, she has AMS, and I want to open this up to the chat, or if anyone wants to unmute themselves, like, what are you worried about her, and what are you going to do for her, and what could you have done to prevent this, or what could she have done to prevent this? And this is a picture my friend took, actually. This is on Denali, so in case anyone's interested, like where this was taken.
So Cassandra, yeah. So you would want to
okay, stop ascent, take a break for sure. Yeah. Are we worried about her getting worse, her developing anything else? Yeah, absolutely, exactly. Progressing to a high altitude cerebral edema or pulmonary edema. Yeah, you can definitely give either aspirin or Tylenol to alleviate the headaches for sure. Are we going to make her turn back? Slow descent for sure. Okay, good. All right, and what could have been done to prevent this? Consider DEX for sure. Anali, great, yeah. We'll get to that in a minute. Diamox prior to ascent, giving, okay, so we'll go to the next one. That was great, guys, thank you. So what are you worried about? One, complications, those were mentioned. Also the logistics, where are you? Are you in a safe place to stop? Are you in a safe place to go back down? How's the weather? What's the time of the day? If you're approaching evening, now's not the time to go down. It may be a little bit difficult or very dangerous, and you may want to set up camp and look at your other options and see what is your available help. At a certain altitude, your options become more and more limited. And look at the severity of her symptoms. They may be getting worse and worse. Her expertise, as well as your group members. What are their experience with this? And I'm saying this now for AMS, but we have to think about this when we're going to get to the pulmonary edema and cerebral edema cases as well. Your treatment goal, of course, is to maintain that functional capacity and prevent any further complications. So I think this was great. Everyone covered a lot of this. So one, stop ascending, take time to acclimatize. Personally, I always take like a few days to a week before a climb, especially if it's a high above 6,000, to acclimatize at that level. And then I climb. Descend 300 meters or more if it's necessary or if it's safe. And acetaminophen or NSAIDs for sure. This is to relieve the headaches. Antiemetics if she's having any nausea or vomiting. And acetazolamide, of course. This is the Diamox and dexamethasone. I put it en parenthèse right now because the Wilderness Med Society, and I also put it here for what could have been done to prevent this, is that it's actually part of the guidelines for Wilderness Medical Society in 2019, that dexamethasone could have been used to treat as AMS. However, on the mountain, I've never seen this used. I haven't seen it used for prevention either, or for treatment, but it can be, and there's a few studies that support this. And again, what could have done to prevent this? Slow ascent, and then there's like, some guidelines as to how much of an increment you should be doing per day, like 500 meters per day. Avoid overexertion. So I've seen this too often between like, a couple of guys who want to race up who's going to get there first and set up camp first. It always comes back to hurt them in the end. Like on day 3 of Kilimanjaro, someone was racing with their friend up to the campsite, and he developed severe high altitude pulmonary edema, was vomiting like a lot of frothy sputum, pink frothy sputum, and had to be helicoptered out actually. So that ended his climb for him. All right. And what if her symptoms were more severe, or if her symptoms did not resolve in 1 to 2 days? I'm opening this up to the chat again. Okay. The movies that lie to you. I'm sorry, Michael. Okay, someone wants to bring out a hyperbaric chamber already. Okay, cool. All right, so just for the sake of time, I'm going to move on. So if her symptoms get worse, again, it goes without saying, descent immediately, give some O2 supplementation. Above 6,000, I always bring O2 with me, and a hyperbaric chamber. So this is what Michael was talking about, or Michelle was talking about before. So what does this do? You bring out, it's actually pretty compact, and it weighs about 5 pounds. If the more expensive, the less they weigh. And it increases your barometric pressure, thus stimulating a descent of about 2,500 meters or more. And that really depends on what altitude you are, right? So the higher you go, the less pressure as you're going up. The O2 content doesn't change, but the hyperbaric chamber can help by simulating a descent. And it's all relative as to what your starting barometric pressure is. So I thought it was just really important to note that 1 hour treatment relieves the symptoms. Yes, that's great, but they'll return within 12 hours. So it's not a fix-all solution. Okay. So we're still climbing. So Barbara's symptoms have improved tremendously. She's great. She did everything that you said and what you told her to take. You're now on day 5. You're at 4,200 meters, and you're beginning your first carry to Camp 1. Carries mean you're going to do this in increments. Like you're not going to bring all your equipment and your gear and so on to the first camp. You might do 2 carries or so on to make it happen. You bring less and less as you go up. So you finished your first day of acclimatization at the Plaza Argentina base camp at 4206. And now Barbara, she's coughing terribly all morning. You thought it was because of the dust from the scree in the air. There's a lot of scree on Aconcagua, but now you're worried. So you go to talk to Barbara and she says she can't stop coughing and she feels so tired that with carrying up that load. Again, other symptoms are fatigue, weakness, shortness of breath on exertion. You go look at her, she's like a little tacky, a little tachypneic as well. And of course you brought your stethoscope. I saw someone put their ultrasound, probably a butterfly IQ that you're bringing on the mountain with you. And you hear crackles starting in the right axilla. So what are we thinking now? Where's the chat? Yes, thank you, Anali. Perfect. So high altitude pulmonary edema. I'm going to close this. Okay, so this affects about 0.2 to 8% of travelers. And of course, I put them over here. If you see my cursor, as you're increasing altitude and the faster you go, you increase your risk of HAPE. So I showed this, this is just the data that's available at over 5,500 meters. Of course, the incidence goes up quite significantly compared to 25 to 4,500 meters. Your mortality rates is 4 to 11% if you treat, 44% if you don't treat. Onset of high altitude pulmonary edema can happen 2 to 5 days after the ascent when you start to climb. And it can occur without any preceding AMS symptoms. It's more prevalent in men, not exactly sure why. I'll leave it to you for that. And more prevalent in people with a history of high altitude pulmonary edema in the past. So as I said, there's like kind of a spectrum for high altitude pulmonary edema. There's mild and severe. So mild is like shortness of breath. You're going to be desaturating, which you're going to find out with your cold Garmin. And it's out of proportion to what's expected for the normal range at that ascent, at that level. Decreased exercise performance. So again, difficulty carrying your load, difficulty just going up altogether with or without a pack, and dry cough. Severe, you're going to have pink frothy sputum that's going to come out, cyanosis, and shortness of breath even at rest, and orthopnea. You may or may not see other signs of AMS or even cerebral edema. And again, as I said before, it can be potentially fatal if it's not recognized properly. So I wanted to put this here at the bottom. What are we thinking in terms of a differential to high altitude pulmonary edema? Thank you, Hajar. I'm not going to comment on that. Okay, I'm going to move on to the differential. I'll put this here because, again, it's important to keep in mind. It's like, yes, it's most likely going to be high altitude pulmonary edema, but also, is it an asthma or COPD exacerbation? What does the patient have, or your team may have? You can think about URTI and LRTI, and I recently added COVID-19. I put TB there too, because you don't know where you've been, how long you've been traveling there for, which diseases are endemic in those regions. Okay, and then, oh, sorry about this. Hang on one second. What's your treatment? What do you think we're going to give for the person who has pulmonary edema at this high altitude? Yeah, someone's using the commercial name. Thank you, Kyle. Okay, good. My portable BPAP. Okay, Lasix, you could use that, yeah. All right. Oh, sorry about making people dizzy with this. I don't know why I went back. I wanted to go forward. Okay. By the way, this picture was taken on Denali as well. It's this is you have to shovel out your tent in the morning. So treatment. So someone mentioned Viagra. Yes, nifedipine or phosphodiesterase inhibitors, right? It's like Rob was saying before, you have a lot of pulmonary vasoconstriction, and what nifedipine does is it reduces that pulmonary artery pressure by acting on the smooth musculature. So just vasodilating. So again, you'll descend until the symptoms resolve. You don't necessarily have to turn back and say, well, like that's your climb for you today. You can avoid overexertion on descent. If it's not possible, what we can do is go back to what we were talking about before, supplemental O2, portable hyperbaric chamber. And sorry.
Attention, code surge, Glen Adult Emergency Room.
So nifedipine or phosphodiesterase inhibitors, not both. No further ascent until individuals asymptomatic, and that's off the treatment medications that you could have done. So you gave. So again, prevention, slow ascent, avoid overexertion. For someone who has a history of high altitude pulmonary edema, they know that they're at higher risk on the next climb to have this again. So they could bring nifedipine with them. Tadalafil and Dex are also alternatives. Dex, if there are contraindications to the two others. Acetazolamide, it can be used. The person's most likely already taking it if they're going at this type of high altitude, but there's no data for preventing high altitude pulmonary edema. All right, back to Barbara. We're now on day 8, right? We have 20 days total. You're climbing through the Guanacos Valley. You're about 5,000 meters high. You take a small break and you notice that she's not acting her usual cheerful self. So your team member was behind her on the ascent, and everyone's following each other step by step. And she was behind her on the ascent, and noticed that she was stumbling in her steps a little bit, not keeping pace. So she feels weird. She's not acting herself. And this is our girl who's like having pre-existing AMS and HAPE symptoms, and she has ataxia. Truncal ataxia is a diagnostic sign of this. I'm going to go to chat. What do we think she has? Okay, great. HACE, absolutely. Truncal ataxia, so it's like wide stance gait, looks like a drunken person. That's very typical of like a high altitude cerebral edema. And altered, and if you brought your fundoscope, which I don't think anyone has ever brought a fundoscope on the mountain, you would see papilledema, retinal hemorrhages, and your neural exam, you may like have a high suspicion of cranial nerve palsies, abnormal reflexes. But very rare focal neurodeficits can also be present. Let's go over here. Again, potentially fatal. It can develop over hours to days in people with preceding symptoms of AMS and HAPE, and it affects about 1% of travelers who are traveling to elevations above 3,000. Ataxia, I think I went over this potentially. So yeah, herniation of the brain is like the primary cause of death in this if it's not recognized and treated promptly. So what would you do for this patient, for Barbara? Thank you, Michelle. Thanks for that. Yeah, okay. Good. Descent in prednisone. Good. So O2, yeah, definitely. Immediate descent or evacuation. So this is not the type where let's go back, rest a little bit, and let's go back up. Let's try again tomorrow. No, you're going to descend. And if the rule on the mountain too is that if you're getting supplemental O2, this is at least with the groups I've gone with, you get it, you have to descend. There's no way that they're going to bring you back up. Dexamethasone, and you just give like a loading dose, and then you give 4 milligrams every 6 hours. Hyperbaric chamber, if you can't descend, if the weather conditions or the time of day doesn't permit it, it's not safe to descend, put Barbara in the hyperbaric chamber. Let her symptoms resolve a little bit, but it's not going to resolve it completely. Prevention, slow ascent, again, there's like, recurring themes to this, and dexamethasone, this is the Wilderness Med Society guidelines with moderate to high risk ascent profiles. On the right side, I took this, I have a textbook that I got many years ago. I don't open it often, but this one, I liked this picture a lot. So this is them, they were measuring their respiration or exhalation during exercise. So this is back in 1939. Oh no, this is 1911, yeah. Oh, how high can helicopters go? Is it oh yeah, yeah, you could do that. On Aconcagua, they will not go over a certain altitude. This is for the question of the emergency evacuation by high altitude, by a helicopter, because their propellers will stop rotating. And there's been quite a few crashes. As you're going, when I was going up Aconcagua, we actually saw remnants of a helicopter debris from a crash that had happened the week before, because again, the propellers stopped working and they weren't able to safely land. So very dangerous. So it really depends on the mountain, the weather conditions, how high they're willing to go. Always good to have a sat phone on you to call for help and check in with the rescue team at base camp. So on Aconcagua at base camp, there's actually a doctor who's stationed there. They rotate and it's really cool. They're making you do exercises and so on, but he would be the person who's coordinating any evacuations on the mountain. Sildenafil, I'm not sure. And I could get back to you. Yeah. Not for cerebral edema. For HAPE, on the other hand, yes. I'll move on to the other one. Okay, so I have some cases here, which I think might be high yield from what I was hearing for the Royal College exams, apparently. So you have a 30-year-old climber. I'm going to start a pulse in just a moment. Okay, I'm launching a poll. So, okay, you have a 30-year-old climber presents to about the 4300 medical camp on Denali and has severe headache, insomnia, loss of appetite, and nausea, satting at 84%, which is normal at that altitude. Lungs are clear, neuroexam is normal. What do you recommend? And can everyone see the poll? Okay, great. Okay, about half of you have voted so far. Okay. Yeah, I'm gonna end it just for the sake of time. So I'm gonna share the results. All of the above, that was the most common answer. Yes, all of the above is correct. So I'm going to show you on this side over here. This is the Wilderness Medical Society guidelines. Halt the ascent. Descend if not is usually not necessary, but see where you're at. If the symptoms are progressing, descend. Analgesics for headaches and antiemetics for nausea. Primary prevention is acetazolamide. Alternatives for severe AMS is dexamethasone. So great, guys, we got it all. Okay, we're almost done here. So the climber, the same climber with AMS at 4300, then climbs to the 5200 camp. He develops ataxia and confusion during the night. What is the diagnosis? I'm going to launch a poll. Oops, stop sharing. Sorry about that. Yeah, this one I'm not going to keep on for too long. Excellent. Good. I think everyone's pretty clear on that thing. Good. All right, I'm sharing the results. Again, everyone was, majority were correct. High altitude cerebral edema. Okay, good. So, 1 second. All right, so what's the treatment now? I'm going to launch the last poll. Stop sharing. Mm-hmm. Okay. Good. I'm going to end share results. Okay, good. So everyone was correct, all of the above. I'll stop share, close this. Okay, good. So prophylaxis, so things that could have been done to prevent: gradual ascent, AMS prophylaxis, the same thing that we discussed earlier. Treatment: descend, give O2, dexamethasone, hyperbaric chamber if you can't descend immediately. All right, So this is just, I included some pictures throughout the presentation just from previous expeditions and so on, but this is more specific to preparing for a climb. First off, it's really important, depending on what altitude you're going for, to trust your teammates. You know, I tend to climb with the same people, mostly because I know that we work well as a team together. But for people starting off, it's good to, like, you know, just you can go with a company, you can go with friends, and take it from there. Again, as I said before, no place for competition on the mountain. It's not time to be racing your friend up to the base, to your next camp and so on. You can see you can get into serious trouble and a very hefty bill at the end of your climb. Invest in good, reliable material. And I have a packing list that I'm going to share with you. I don't mind if people take screenshots of it. And it's really, I have packing lists for all types of mountains, whether I'm doing primarily ice climbing or just a rock climbing versus mostly glacier travel. Start touring early and wisely. So this really depends on what type. For Aconcagua, I trained for a year, and I'll tell you what I was doing before. Allow for sufficient time for acclimatization, and check in with yourself often. So it's not good to just continue ignoring your symptoms and so on. Just be aware, like, I know that I have paresthesias. I'm not going to stop climbing because of it. I know it's mostly because of the diamox, but it's good that I'm aware, and treat yourself. Like, I meant that. I used to just say, like, bring chocolate, like whatever your go-to is that's going to make you happy on the mountain. It's not easy. You're climbing for long hours, and it's nice to treat yourself at the end of the day. All right, so packing list over here. This is what I brought for Ecuador. I did 5 summits there, and it was a lot of ice climbing, and that's what I was working on. That's what I wanted to work on personally, my personal objectives for my next climbs. So clothing, I broke it down into clothing, technical gear, bags and containers, first aid, and food. And I actually have a YouTube channel where I explain how to size it, how to use it, how to layer it, and how to prepare overall. So there's about 7 videos there. In case anyone's interested, I can send you the link. All right, and then for training, be intentional, be specific. So like aerobic exercise 3 to 4 times a week. So what I was doing mostly was a lot of Stairmaster, or going up and down Mont Royal, or even Mont Orfort, like, or Saint Bruno, I went to a few times, just with a loaded bag, and I would increase that load every time I would go. Or, you know, depending on how heavy the load is, I'd do it a few times and then increase the following time. Resistance training, again, your power comes from your legs, and steep uphill training, of course, with the loaded bag. I already said that. Breaking your boots ahead of time. I had a friend who had to get helicoptered out of Aconcagua on day 2. Well, as soon as we got to base camp, because he got big blisters. He hadn't broken in his boots before starting the climb. It's a very expensive climb, and he had to spend about, I think, 2,000 American getting helicoptered out. And also important to think about, does your mountain involve any glacier travel, any ice climbing, any crevice rescue or self-rescue that you need to know before going? And do you need any permits and outdoor survivor skills? That's where the Wilderness Med group comes in. And that's it. Thank you guys for listening, and we made it. Okay, I'm going to mute myself, and I guess
yeah,
for sure.
To cut you off, so your timing is perfect, Cassandra.
I think that's Audrey who said that, walking up Côte des Neiges to the MGAs, for sure.
So thank you very much, Cassandra and Rob. Great presentation.